Perfect. Well, welcome everyone. It is great to be here, and I believe we are now officially started and kicked off. My name is Kirk Barnes. I'm the co-founder of TransferMed, based here in Atlanta, and it is a pleasure to be joined with such a powerful panel of guests here to talk about the virtual care, especially post-pandemic, and I say post during the pandemic. We're not through it yet. Maybe I spoke that into existence, but I have some phenomenal people here that I would like to start off with a brief round of introductions to let you know who we're going to be spending some time with today. So, David, let's start with you to talk a little bit about who you are, your firm, your background, and we'll kick it off with you.
Sounds good. Thanks so much again, Kirk, and thanks for the opportunity to certainly be here. It is certainly an honor. So my name is Dave Curry-Guntla. I did a couple years of research at NIH. Found myself wanting to spend more time with patients and went off to medical school and was headed to a vascular surgery residency and realized that we spend a lot of time putting very expensive things into patients, waving goodbye, and knowing that we've kind of treated the symptoms but not really the underlying disease. And so the question was, how do you actually really fix that disintermediation between patients and clinicians? And the answer was with sensors and software. So decided to disappoint my parents a little bit and turn down a vascular surgery residency and start. I was going to take a year off actually and just put this with my co-founder and then go back to residency. But 8 years later, here we are. We initially started off by doing that on the implantable side, but made a pivot to the wearable today to be able to get to patients in a more get to market quicker, quite frankly, and showcase for the world what we can do. So Leo is an end-to-end remote patient monitoring platform that starts off with a wearable that's worn by the patient. It's very easy for them to use. It's deployable. And then on top of that has more metrics than anyone today. We get your basic vitals, but also things in terms of heart failure and blood pressure and even electrolytes and small molecules, which is where we're leveraging the AI engine now. So pulling all that together to do total patient management for some chronic care conditions like kidney disease, heart failure, and others.
Fantastic. Thank you, David, for the background. I'm sure your parents are very proud of you now. I know
They have a
that
grandkid now, so it's okay.
Yeah. Oh yeah, they're good. They're good to
Good.
go now. They're good to go. Right. It's not about you anymore.
No,
So
not at all.
fantastic.
Don't
Well,
even know
thank
my.
you, David. Right, right. Thank you for your background. Richard, I'll go ahead and allow you to introduce yourself.
Sure. Name is Richard Gooden. I am the program director at Morehouse Healthcare for our telehealth program. Our program launched in 2018. Prior to that, actually, interestingly enough, my background is in communication. So I'm actually a journalist by training and spent several years covering the military, covering sports. I covered just about everything for a while. I was an editor for a while and made a transition into public health. I took a job to start a communications department at Morehouse School of Medicine, was hired by Dr. David Satcher, who was the 16th Surgeon General, and my department was under his. And that was a great opportunity to learn a lot about public health, far more than I ever expected to learn. And the amount of exposure and amount of opportunities that came from that was great. Transitioned that into into telehealth. So wound up doing a lot of peer-to-peer education programs where we had providers training other providers on health-related matters, and then now transitioned that into what I'm doing now, which is more focused on patient-provider relationships in telemedicine. So my focus is really looking at improving workflows, improving access, improving the patient experience, improving the provider experience. That's my area of focus. One of my many passions, but definitely enjoy this work, and it kind of gets you all over the place. So I definitely enjoy that part of it.
Amazing. So thank you, Richard. I'm sure, again, you've done some phenomenal work and working for Dr. Satcher. I can only imagine what you were able to digest being under his tutelage. So I'm sure a lot of that will be banter for our discussion today. So thank you for joining us. And last but not least, good friend, Dr. Tina Shaw. Welcome. It's good to have you here, my friend.
Thank you so much. Kirk, can you hear me okay?
Yes, I can.
All right. And my apologies to everyone about being late. Of course, we're talking about digital health and digital stuff, and I had digital issues. So. But I guess just to introduce myself, my name is Tina Shaw, and I'm a practicing pulmonary and ICU physician. I have over 10 years in healthcare across policy, digital transformation, and implementation work. Most recently, I served as the medical director for virtual health for Wellstar Health System in Georgia, where we, kind of went the gamut of the things during the pandemic with launching ambulatory telemedicine rapidly during a pandemic because of the urgency, as well as thinking about unique ways we could bridge some of the problems we saw on the hospital side when we had to close our doors, and what happened with patient experience, with physician burnout, and with just trying to make sure we had enough PPE to make sure all of our clinicians were safe as we took care of patients during the pandemic. Prior to this, I also had the opportunity to serve two presidents, and I am proud to serve my country under both President Obama and President Trump. In this capacity, I worked at the White House as well as was special assistant to the U.S. Secretary of Veterans Affairs, one of the oldest users of telemedicine. They're now close to 15 years into their telemedicine and remote patient monitoring journey. Thanks, Kirk.
Phenomenal. Thank you, Tina. Glad you made it. And just to give everybody kind of the lay of the land, we're going to have some questions that we're going to address over the next probably 35 to 40 minutes, and then save the last 15 minutes of our time together with some Q&A that will allow the audience to ask some questions of our outstanding panel. So that's the lay of the land. So let's get right into it and get things kicked off. And since, we've had a couple of people touch upon COVID-19 and talk about the challenges of delivering care, right, in the middle of a global pandemic. But there was a before, there's where we are now, and kind of, what we see afterwards. And so in terms of virtual care, and David, I'll pick on you first. In terms of virtual care, maybe what was life like before COVID, and kind of where is it right now from the lens from where you sit? Talk a little bit about that.
So I think in many ways, as we all know, there was an uphill battle to bring a lot of virtual care into medicine, I'll say pre-COVID. I think we all know that it's been very much upended in terms of telehealth. But I think also, while telehealth, certainly that connection with the physician, I think of being able to do that over a video screen, if you will, has certainly been impacted. I think the need for data behind it has also come into the light. So it's not just about how do I connect, or where can my patient be, or where am I as a physician, but also, well, what data do I actually need to help that patient? I think we've all seen the proliferation of wearables in terms of health and in fitness. I think it's really pushed into, well, I need clinically actionable data. And I think that's always been a Leo's mission, certainly has been to give clinically actionable metrics for chronic disease. We saw that chronic disease patients, whether that was kidney disease or heart failure, they're the most susceptible to COVID, from an underlying comorbidity standpoint. And so being able to keep them out of the hospital, I think, has brought to the consciousness that it's not just about seeing them, but also getting data to be able to help manage them from afar. If we think, I'm sure Tina probably has some comments about kind of the ICU at home aspect that I think can be, I think the big reason that you can't do that right now is, am I getting the metrics that I need? Am I getting them at the clinical grade accuracy that's required to actually impact their care? And I think that's what will really make things sticky. I think certainly for us, that was something that we saw that was important. It was really engaging the physician at that level, and that really kept a lot of our clinical work ongoing. But what really was able to accelerate some of that clinical work even during COVID, even though most of the clinical trials had to be shut down, couldn't really get into a hospital, couldn't do some of our ICU work, the benefit was that we could deliver our product directly to the patient's home. And so we really focused as a company on the user experience at both ends. So the physician user experience of getting clinically actionable metrics, but the patient user experience of, this is simple for me to get up and running. And if it's not, then I think the compliance decreases. If there's 10 things I have to do every day, I'm not going to do it. My doc's not going to get the data. It's not that valuable. And I think that's really brought to light that you really need to focus on the user experience at both ends, and you have to focus on clinically actual metrics. And we see people being a lot more, very responsive now, as opposed to maybe before it was, what does this cost me? How hard is it to implement? I don't know about this idea. Is it reimbursed? And now it's very much, if I get those metrics, I understand how I can treat my patient differently. I think that's been despite all the, if there's a silver lining, if you will, from a COVID perspective, I think that's it.
Fantastic, very rich insight. David, and I'd imagine Tina, since you were mentioned in the last set of comments from David, I thought I'd let you kind of speak up, especially since clinically you were right in the throes of it when everything was happening.
Absolutely. And, David, back to you. Where were you before the pandemic? We could have used you at Wellstar. Let me say that. Well, our journey it was for sure, like everyone else's, accelerated, and we were empowered because of the pandemic, agreed as a silver lining. And to give you some context, our health system's virtual care journey, we had planned out for 2 years that it would take to really launch telemedicine in the ambulatory space. And a lot of this is really shaped by the poor reimbursement scheme pre-pandemic. So, you have to make sure your lights are on. Of course, you want to do the best possible, most convenient care for your patients, but you have to be, realistic with what is your profit margin so that you can keep everyone employed and still continue to deliver good care. And so I think we were planning on having this slower rollout. Like many other health systems, we had launched a cash pay direct to consumer urgent care service. And, again, that helps us give patients access. We found that there are many places in Georgia where folks are in rural areas. It's not easy to get to a clinic, and they all of a sudden at least had access to care right when they needed it if it was something urgent. Now let's fast forward to the pandemic. So I think on the ambulatory side, and Richard, I think you're probably going to say the same thing, but it's like the lights got turned on overnight. And in my health system, we didn't have all of a sudden, 300 tablets to give out to all the physicians. So we used what we had. Sometimes it was our own devices. But the key was giving the clinical team the need to know information. Yes, you can bill for this. Yes, we want you to do it. Here are the 3 things you have to drop in your notes, and here's the 1 code you need to drop for billing purposes. And on the back end, we kind of streamlined processes and took that outside of the care team because care teams were stressed by so many additional measures. And then on the inpatient side, I really think while most of the innovation, in my opinion, with telemedicine pre-pandemic in the private sector, that is not VA or not other federal government-backed health systems, was actually in the inpatient space. My health system had already some telestroke care for those places that really did not have neurologists on staff, but we experienced something so unique. All of a sudden, the lines got blurred between inpatient and outpatient. I think this is just crazy to imagine. So I'll just share with you a story, Kirk. We had an EP doctor, so a very advanced cardiologist, who would travel hours, and in 1 week he would go to 3 different hospitals, of which one was a 2-hour commute each way. So you can kind of imagine this most precious asset, spending time driving, then going down, seeing the patient, when ideally he would be in the cath lab doing procedures and helping patients, more efficiently. And so when telemedicine happened through the pandemic, we made him a true virtual doctor. So whenever he had a break, he would either pick up a clinic visit and he would do telemedicine sitting in one hospital and seeing a patient in their home, or he would go down and virtually be part of Wellstar and LaGrange, and he could do these consults, so that when he was physically at these locations, he did that one part that required him to be there, in person, so he could do the procedures. And I think this is incredible, right? So we know there are shortages in specialties all across our country. In Georgia, especially, I think OBGYN is this one that's gotten a lot of attention. And think about what we can do now post-pandemic, because we know how to blur the line.
Right. No, great feedback. And I think, Tina, from comment you made and being able to take a specialist and allow them to have access to their patients no matter where they are, I think, that was conceptually where we wanted to go, and COVID kind of forced us to get there quicker. But we know that access to care, even in that setting, is not equal across, the entire state. And so, Richard, one of the things I would love for you to talk about and maybe kick off the discussion is the not so pretty side, or the challenges associated with delivering virtual care to rural populations and even disadvantaged populations, because even as we talk about innovation and who gets access to care and kind of the latest and greatest, many times it's the rural and the disadvantaged populations that don't get that, whether it's a function of reimbursement or just a function of bandwidth, whatever the case may be. But Richard, I'm sure that you could speak very, very passionately about that. So let's hear your thoughts on that.
Yeah, definitely. So for us, it's interesting because COVID never changed that for us. So for a lot of organizations that almost, they had to kind of repurpose and refocus on something. But for us, that's been our normative. We're one of 4 historically black institutions in the country that have medical schools. So we've been working in this space forever. So that was one of the things that it wasn't a big shift. We had shifts in other places to get people to adopt telemedicine and to allow them to know that they could provide the same quality of care. But when it comes to working with rural populations and working with underserved populations, that really wasn't a challenge for us. We really needed to look at that next layer of the embedded challenges there of how do you get these services to them, their internet access. So some of the things we really looked at doing and benefited from in our rural communities, we looked at creating presenting sites. So people who didn't have high quality internet at home could at least benefit from maybe traveling 10 minutes to go to a clinic and then see our providers virtually instead of having to travel 2 or 3 hours to see that same provider. We also worked with those sites to make sure that our technology wasn't disrupting their workflow. Because very often you hear about these examples of, hey, this is going to revolutionize what you do, and you're at this little practice and it completely alters and changes what you're doing for the worse for them a lot of times. So we really took the time to sit down with our rural partners to develop workflows that worked and supported what they were doing and made it easy for our docs to block out their time so they can provide the specialty services that they needed. And then even as it related to the technology side, we leveraged our IT department within our institution to assess and make recommendations and even sometimes work with some of those sites to go to these rural sites to make sure that they had the infrastructure to support this type of technology. Because obviously telehealth, telemedicine, all of that is great, but if you don't have internet access, it's useless. So some of these sites, and again, probably not too surprising to the folks on this call, internet is not as abundant as it is in the metro areas. So those are some of the things we did within our rural populations to really work with them to facilitate that. But then you have a different set of issues within our metro community. So within Metro Atlanta, we really wanted to take advantage of direct-to-consumer solutions. So we wanted to make sure that our direct-to-consumer solutions were easy to use. We built in time for our schedulers to walk our patients through setting these up. We also built out a system, just like our in-person system, where we have virtual triage so that they're getting a call from the medical assistant prior to their visit, just like a medical assistant would take them in the room and work them up and get them ready for the doc. So we wanted to make sure that everything was on par on our virtual side and on our in-person side, to just make sure that all of that was equal and on par. We increased access to education for them around chronic care management because we understood these are our most vulnerable patients, and we want to make sure that they know their vulnerabilities, they're aware of them, and that we're linking the education to the technology. And also understanding social determinants of health and understanding the challenges as it relates to transportation, the cost for parking, gas, all of those things. When you take all of those things into consideration, I think it helps for a more conducive health experience for our providers and our providers and our patients. So we really make this a patient-centered experience at the end of the day, whether you're a vulnerable person in rural Georgia or you're in Metro Atlanta. We really wanted to make sure that we made the concessions to make this as easy as possible for the patients, even if that put a little bit more challenge on our internal staff.
Right. And I think that's one of the things when we are talking about innovation and technology, understanding the patient's perspective of what it means to them and what it means to adopt. And David, as a solution provider, maybe talk a little bit about what it's meant for your business and making sure that the technology that you have is accessible to rural or disadvantaged, where they may not be used to using this type of technology to accept care or even access care. What challenges have you had in maybe working in this area from your perspective?
So it was interesting to talk about kind of the advances of telecoms and what that has, I think, really liberated or democratized healthcare in so many ways. So I think one of the first places even where this idea around Leo came from is my father does a lot of medical missions spent a lot of time both Peru and Zambia as well. So I was out on a trip with him to Zambia, and it was a sort of spot where you land on a commercial flight, hop into a private plane, have to buzz like a bus, like a little private like landing strip, make sure the animals get off, and then you can land kind of spot. But still, all the way out there, my MTN SIM card still worked just fine. And it was a very interesting question to those clinicians, which was, well, you're getting a lot of donations from, European, US hospitals. You've got stents, you've got all these other devices. Why aren't you using them? The answer wasn't because we can't or we're not trained. It was, well, we don't know how to get a contact to the patient if something goes wrong. So we're taking the most drastic option just because we can't contact them. So that became a very influential piece of what we thought about from a design process. And I'll say two comments on the design process. One, spend time with your end user. I think a lot of companies think about, how do I sell into the health system? How do I make sure the doctor likes it? What do I have to do? And not enough time with the end user and understanding their needs. And we actually took our entire engineering team into a dialysis clinic, which is kind of our first area of focus, and we actually had them spend an entire week basically following an entire patient life cycle over that week of going home, transport, all of the difficulties of their of a week in the life of a patient, if you will, to help them understand what they had to do. And that actually led to kind of the aspect of when it came into the product, things like just making things shower proof, sweat proof, making sure that it was easy to replace. Are things big enough, for your patient population to actually hold, and so it doesn't fall out of their hand? Can they place it at home by themselves? I think is big questions. And then we come back to the telecoms piece, and I think Rich brought up really well, which is there's a reason we don't have a smartphone app or require Wi-Fi right now. We actually give a little bedside hub with the patient because we're doing chronic care diseases and they're going to have this for a long time. They can actually plug that in at their home. The patient doesn't have to touch anything on their patch. It's all passive. Whenever they go within range, about 30 to 100 feet of that hub, it's automatically uploaded via cellular signal. So it is true plug and play, which means that, to the exact question of, we didn't want to exclude anyone that didn't have cell signal, that didn't have any other way of making this happen, for getting that data to the clinician and that clinic, the actual metric was really important. So I think starting with design and then really living the life of your patient's important from a solutions provider, and that I think doesn't happen enough today.
Yeah. No, great points. And I know there's been a lot of talk, especially as you touched upon, the broadband access and getting data through the cellular networks, also the policies that are put in place to help support and drive all these changes that are moving at light speed. And we know that technology does not wait for policy to catch up. Unfortunately, policy has to kind of, play catch up. And so we're very fortunate to have somebody that's been at the front seat of policy in a good perspective and lens and what that looks like. And so, Tina, talk a little bit about, from your experience from the White House, maybe the national perspective and some things that we may not think about or take or really comprehend on what it looks like to drive, this change in care from the national perspective when we're talking about policy.
Absolutely. And I'm going to try my best to keep it succinct, but I think this is where the money is, because all of us working on the front lines, how many times have you had this question of like, this is the worst possible, regulation? It hurts basically every single person, most notably the patient. And I think it goes back to basics and thinking about civics. And the two pieces I want to talk about are our legislative branch and our executive branch. So let's take the story of telemedicine. So historically, before the pandemic, we really weren't using telemedicine, at least on the Medicare side. And a good rule of thumb is when Medicare sets policies, all the other insurers follow. So that's why this is critical, what Medicare does. Congress had passed coverage for telemedicine with a few caveats, and these were the two caveats. A patient had to be in a rurally designated area. Now, I think many of us can, sort of give guesses and pretty accurate guesses at which parts of Georgia we consider rural. Surprisingly, the majority of the areas we would think are rural in our state don't actually qualify as rural for this purpose of this. So there's a special HHS, Health and Human Services designation of what's rural. And then further, the patient had to actually go to a healthcare facility to then receive telemedicine. So I think we can understand why. I mean, my definition of telemedicine is I could be sitting on my butt anywhere and I should be able to see my doctor, right? But legislatively, while well-intended and probably appropriate at the time these laws were passed, sort of inappropriate now, and as you said, Kirk, kind of outdated. So we had one piece which was legislative that was binding, and then you had Health and Human Services, and under their purview is to take laws and actually enact them, and then set regulations which are a little bit more of the script that we can then use to know what we can do and get reimbursed for and what we can't do. And the operative word is operative phrase is how do we avoid fraud? How do we do right by patients, but make sure we don't commit Medicare fraud? So despite, I think, most people wanting to expand access to healthcare, whether legislatively in Congress or at Health and Human Services, you can kind of see it's not that Congress was working really quickly. It's very hard to get legislation passed and updates. Not shockingly, telemedicine wasn't on the table. And we had Health and Human Services that literally had no legal ability to do this until we declared the public health emergency, at which, if you recall, there were all sorts of waivers. And these waivers allowed us to finally unlock. And it doesn't matter where the patient is, and they finally don't have to be in some healthcare facility to get telemedicine. So I just wanted to give you a sense of the two pieces. And I'm going to leave a third piece. And honestly, I wish I knew this in med school or even in my first 5 years in practice, because I didn't. But there is actually another layer, and I like to call it the subreg layer. And this is where, I think you want to make sure it's the dog wagging the tail, not the tail wagging the dog when it comes to being in that provider group or that health system. Medicare sets loose guidance called regulations, and then it's interpreted by us in the field. So you have compliance and risk and billing and coding and revenue, and then finally some sort of medical type, a physician, a nurse, etc., right? And when you put all of these pieces together, there is often so much of a concern that we may commit fraud or do something incorrect that we often become even more restrictive. Case in point, when we started implementing EHRs, there was a myth that only physicians had to type in the orders, and that was actually the interpretation of regulations that was incorrect. And so this has been busted, but you can get a sense of what was also happening when it came to virtual care. We were so risk averse that our interpretation, our subreg level interpretation might have been incorrect.
Wow. So Tina, I think out of all that I hear that you'll be teaching a new course.
Yeah, right.
Yes, the fee is $1 million. If you sign up, that would be great.
Exactly. No, that is valuable insight. And sometimes, when you hear it, it's like, how do we get anything done? And so I really appreciate your perspective. And Richard, I'd imagine, from the work you're doing at the state level, you probably have a lot of experience on how policies will shape how you deliver care, especially in this virtual world as well.
Yeah, that did define a lot of our relationship. So we really, and one of the benefits of being in Georgia was, I would say, compared to other states, Georgia was not as far behind as they are in other things. So Georgia was not in the worst position possible. And the other thing that's interestingly beneficial is so much of Georgia is rural. So there's so many people who apply. I mean, who would benefit from these types of initiatives. So being in Georgia from a state level, we still ran into some of the issues where patients had to go to a presenting site. There wasn't even a choice. That was their only way of getting telemedicine services, which is challenging and disheartening because sometimes they're getting the exact same services as their peer, and the only thing that's different is their peer is going to have private insurance and they have something different. And because of that, they have to travel to another location instead of being able to get it from their home. But I will say, I commend the relaxation of a lot of the restrictions, the opening up of different platforms. You were basically able to use just about everything except TikTok during the start of COVID. So those types of things show that this can be done. And I think that was one of the things we discussed. What we were doing, especially during the initial shifting of a lot of these policies, we were conducting quick webinars with our team and with other clinical teams, anybody who wanted to participate, to just have discussions, because just as Tina recognized, a lot of these policies are complex to understand at times. So even when they say you can do this, you're wondering, well, how much can we do? So it's good to get the compliance people and everybody on the same calls to say, this is what we are saying we believe we can do, and everybody is in lockstep with that. And that really did help us long run. And what it also does, to be honest with you, is it's allowed us to leverage technology in a way to reduce burnout of a lot of our health professionals. I know you'll touch on some of that later on, but that was really key as it related statewide, because as you know, some of the policies required you to go out and see your patients every 3 months, and there was periods that you actually had to go out and visually see these patients. And that, again, puts our providers in a space in which they're not providing care, but they're on the clock. And that wasn't always the best use of their time.
Right, absolutely. And a couple of things I wanted to pull out. You talked about physician burnout, and also how this policy drives reimbursement, what gets paid for, things of that nature as well. And on top of that, just a couple of discussions I've had during this time frame is one of the most dominant either codes or things that are being reimbursed is the need for mental health and mental health care. So maybe talk a little bit about, Tina, I can go back to you, or David. Tina, I'll go back to you to talk about, what is happening right now in terms of addressing the needs of mental health, especially in light of, between the pandemic, between, a lot of the social unrest and social injustices that are happening, people that have been on the front line, as you just mentioned, Richard, the doctors that are on the front line, clinicians that are on the front line. Talk a little bit about things that we could do for both patients and providers in terms of the mental health right now.
Absolutely. I think before the pandemic, the coverage for mental health was somewhat there as far as telemedicine goes. In fact, there are separate codes for mental health. I'm not saying it was smooth. And for example, in Georgia, I think if I recall correctly, Medicaid did not have coverage for mental health, but some of the other insurers did. So I'm not saying it was perfect, but we had some coverage. Now I think it's unequivocal that we have the president, we have heads of science, preeminent physicians across the country saying our rates of depression and anxiety and trauma are so high as a nation. And then on top of that, if we were to just limit ourselves to any healthcare worker beyond physicians, we're talking about every single type of healthcare worker. Yes, we're not measuring it exactly, but I think we all know that burnout rates are much higher. And a component of that is mental health. So I feel that, again, a silver lining is there's more of an acceptance of the need to get this kind of healthcare. And we're no longer saying, your ankle's broke, walk on it. I mean, that's kind of the mentality we had for mental health coverage and mental health access. Now we understand. And I'll say for nurses particularly, and physicians and other healthcare professionals, because we have staffing shortages, and because some of it is we've become ill, or unfortunately we've expired because we ourselves have had COVID, or we're just burnt out and we leave the workforce. There's even a business case now to have good, sufficient private access to mental health care. So I foresee, when we think about reimbursement too, that this is probably going to be at the forefront when it comes to virtual care reimbursement, because it is mission critical for keeping our health system up, and then thinking about the productivity and the growth of our GDP as a country.
Yeah, fantastic. Yeah. And go ahead, Richard.
Oh no, I was going to add two key things that I think need to be considered in this space. Is the model, and I know especially in Georgia, but I'm sure this is a national thing, is the model we use for payment. We're almost pushing our mental health specialists to go to cash paying patients only because the reimbursement levels are so low. So it's not competitive to accept insurance the way it's designed, which is furthering that gap for people who are actually in need of these services. But a lot of our behavioral health docs right now, even, especially even on the front lines, are primarily to sustain their business. They are only taking cash paying patients. So that is something that really, really needs to be considered. And then the other thing that has to be considered is there's a shortage as it relates to behavioral health specialists. So how do we look at expanding the pool of behavioral health specialists and considering other professionals who could potentially get training to provide the services that are necessary to help heal the communities, especially for the things that people are constantly going through and dealing with. The pool of providers that we have right now just isn't enough, and the illness is really outpacing the number of providers who we have who can even provide help. And the recognition is those providers need help too. So it's clearly a situation where we need to reinvest how we train people to provide the service and not make it so exclusive.
Absolutely, great point. And especially when you talk about the providers and people on the front line, and even before the pandemic, what was becoming more prevalent, just like mental health awareness was increasing, the awareness of physician burnout and what that was looking like, and has been just exacerbated by the pandemic and dealing with COVID as well. And so, David, I know you talked a little bit about the different type of diagnostic virtual tools that you have, and I think there's even some that you could speak to that could help with assessing or monitoring physician burnout. Maybe you could speak a little bit about that for me.
Yeah, so I think one of you kind of mentioned, I think a little bit about joy, and I think that's certainly one of the things that we talk about is kind of from one of our mission statements is, bringing joy to patients and physicians, like keeping that at the forefront. I think when we think about tools or being kind of from a solutions provider, it's, hey, we're adding one more thing to your, to your tool chest, and that can actually be pretty tough for physicians, right? Oh no, one more thing to look at. And I will say that there's maybe two things there that I think are really important. One is your design. So thinking about how does this make sense for the clinician, and does this fit into their workflow or not? If it doesn't fit in their workflow, it's one more thing that they have to do. You're contributing to physician burnout. So think about that from that standpoint. I think for us, once again, with a dialysis clinic that has, when we're working with some of these centers that have hundreds of patients, they don't want to have to look at if we ask them to look at every patient every day and the data that came in, they would be deluged and they would never do it. But by actually taking on the standpoint from the regulatory side of being willing to be patient as a company and go through the regulatory hurdle of actually getting an alert to a clinician, that means when they walk in the morning, here are the one or two patients that had a problem overnight. That's a lot more simple, and I think actually reduces a little bit of that cognitive overload of, oh my gosh, what's going on with the 5 patients around me? It's actually much more about, here are the 2 patients that I actually have to take care of. And I think that's actually been helped on the policy side. I think both Tina and Richard have talked to it, which is previously some of the changes that were there was you had to spend a lot of days logging in, if you will, and looking at data. You also had to spend a lot of time looking at that data. And now those restrictions have been really reduced, which I think is very valuable. And the last, regulatory and policy piece I'll say as well that maybe folks aren't as aware with is some of the Stark rules and the anti-kickback rules means companies can actually, especially RPM companies, can work with others, can work with other telehealth companies, or can work with other med device companies as well in a more comprehensive way. And I think that's really going to accelerate the adoption of realizing that not everybody has to have a contract with the right payer and the right provider and the right physician. And I mean, on the consumer side, if you think about your in-network and out-of-network PPO and HMO plan, it's kind of the same thing coming as a solutions provider of who the heck do I work with and where do you actually get paid from and how do we actually solve this problem? Now it actually, I think, reducing that barrier really will help on the physician burnout side too of, well, I can only use this tool with this patient population or I can't use it here. How do I get it across my entire hospital? I think that's really going to change because there's a lot more flexibility in the system than there was before. And I think those tools can now be more dedicated to the physician experience as well, not just what's the lowest regulatory hurdle for me to get into the market. And I think that's a big mentality shift that, at least from the solutions provider side, will help do our part, if you will, to tackle the physician burnout side.
Yeah, absolutely. And Tina, we had a discussion about this, last week, and as we're talking about mental health, but specifically things that address the, clinician burnout, and really just to go as far as what are things that can be done to help bring joy and light right to the clinical forefront. And given that you touch technology, you're in healthcare, you work at with the White House from the policy perspective, and even a large health system, to put you on the spot, if there were 2 to 3 things you think that could be done to help increase the levels of joy or satisfaction, even as far as happiness among clinicians, what would you say, or what would you prescribe those things to be if you had your way?
First, hire me as a consultant. I mean, that's the but to give you two concrete things, they are surprisingly simple. So if we look at the burnout literature, and I actually sit on the Clinician Wellbeing Collaborative at the National Academy of Medicine, we estimate that 85% of what drives burnout, and it's not exactly the opposite of joy, but it's, addressing burnout is how we get to the path of having more joy. 85% of that is workplace factors. So it's about like what tools we give providers, what are they working at the top of their license or not? But let's imagine a scenario in which you don't have additional resources. You don't even have enough staffing. I mean, this is like present day healthcare delivery, right?
Right.
And what are two things you can do? Here's the most underutilized treatment for burnout. It is recognizing the daily heroic acts that everyone is doing. So if my direct supervisor does a shout out, even as simple as that, on a monthly gathering of my division, if my supervisor does that, that actually is a free treatment, but is a very effective treatment that puts us closer to joy. And then the second piece I would say is actually helping physicians and nurses to get rid of stupid stuff. And there was actually a perspective piece literally called Getting Rid of Stupid Stuff that was published in the New England Journal of Medicine in the last decade. And this is coming from University of Hawaii, but literally, there was a physician leader there, and she went around and she asked, hey, what needs to be retired? What's out of date? What's stupid? And they serially knocked down one by one these things. Some of them couldn't be knocked down, but they were able to give feedback to whoever submitted this request so that at least you got kind of closed loop understanding as to why not. But simply that act of, one, making life simpler by retiring things that were considered just low value or no value. Okay. And then it's also taking in the input from frontline workers. These are the ways we can get to joy quickly when we don't even have additional resources.
Yeah, it's funny how far just being heard can go. Heard and recognized, right? And you don't have to have a clinical degree or a title to do that. Those are things that are free, as they say, free 99, don't cost anything, a little bit of time, but everybody loves to be heard and then have some recognition. So thank you for sharing that. And I'm sure everybody will want to hire you as a consultant to point these things out, Tina. So we all get some residuals from the business that you get from this. But we're right at about 1:42. In the interest of time, I'll ask one final question, and that is, with all the technology at our disposal and the pace at which new tools are coming onto the market with innovation and digital health especially, it's paramount as we talk about both the patient and technology, but having the balance between the high tech, a lot of the things like David has his company, and a lot of the new tools that are coming up, but also high touch, because there are a lot of patients that really suffered because their social interaction was going to the doctor's office, was going to meet people while they're at the hospital. So that high touch part is just as valuable as the high tech. But how do we, moving forward, because virtual care is not going away, but what are things, maybe Richard, I see you clasping your hands, things that we can do to keep top of mind the balance between high touch and high tech with our patients?
From our experience, it's been empathy-based understanding of social determinants of health. So really understanding that, I'm trying to accept and understand that our patients have challenges. We have everyday challenges in the clinic. They have everyday challenges getting to the clinic. They have everyday challenges beyond that. And I think if we don't just pay lip service to it and look at it as an academic exercise, but really, really try to employ that type of empathy to understand that these are real challenges that they have and these are real people, I think that that's one step. The other step is, and this is one of the things, it'll sound odd to hear a person who loves telehealth say this, but telehealth isn't for everything. There are going to be times that you have to bring somebody in and put your hands on them, talk to them, look them in their eyes, all of the above human affirmations necessary to strengthen the people that, whether these are our patients or the people that we work with. So I'm not a believer that you can just do everything virtual. And so that is another thing that we need to convey And I think it's also important for our policymakers and even our business leaders to understand that a lot of this is going to be defined around the dollar and around how we incentivize the dollar and who we incentivize that dollar going to for doing what. And if we continue to disincentivize providing care to our most vulnerable populations, we're just increasing this gap of health disparity. So again, a part of it is just that dollar and where is that dollar going and what's the incentive for what we're paying. So at the end of the day, I do think empathy will play a major role in all of those decisions there.
Fantastic, fantastic, great. Thank you, Richard. David?
So I think I look a little bit of that high tech kind of to high touch. A great vignette comes to mind, which is actually the first patient we enrolled in a clinical study, and we were going to talk to the patient. It was right before a procedure to unblock his vascular access to continue with his dialysis treatment. And unfortunately, they clot very often, so sometimes they have to create new ones, and there are only so many places you can do that in the body. So it's a pretty tough cycle. And his wife was with him, and she was kind of a little bit resistant at first, and so we kind of she kind of came back out and said, "Can you tell me a little bit more? Are there any needles?" We said, "No, there's no needles, so you don't have to worry about that." So that was okay. In that case, I'll let you use it. But what was interesting towards the end of it was when we took it off, and she asked me a few more questions, and she said two things that has really stuck with me, and I tell our team all the time about the impact that we get to have. One was she said, this kidney disease especially is often seen as a conveyor belt to a patient's demise. It's something that they're on. They don't get a choice in it. They're just told what they have to do. You're up for a transplant. Maybe you just got to go to dialysis. But suddenly when we said this patch will help monitor the reasons that you have these, you go to the hospital, maybe maybe your access fails. She said, wow, I feel like we are empowered to actually be a part of our care because I now get some of this data too. I'm involved. No one's ever involved us in any other decision. It's just been what we've been told we have to do to preserve my husband's life. And so I think that there's that sense of empowerment that comes, somebody's paying attention to what I'm doing is a really important thing. And as I walked out, she kind of placed her hand on her husband's other arm and said, I wish we would have had this earlier because we could have saved your other arm. And I think that's, just if you think about that, not just, oh, I'm getting data and we're going to put machine learning behind it and it's going to be great. Like, it actually has to, think about what this means for a patient and their family, I think is really important and really brings that connection between, I think, high touch and high tech is certainly important for what we're doing.
Great context. And Tina, you want to bring us home and give us your perspective as well?
Sure. And I think there were so many key things said both by David and Richard. So I'll try and offer a little bit more narrow but a slightly different reflection, which would be to say, just because we're on virtual doesn't mean we're translating what we do in person and putting it on virtual. This really is a different way of doctoring. But on the other hand, it's not that we aren't used to it. We use telephone, we use some sort of text-like function. These aren't new technologies to us. And I think we can go back to basics. On the clinician side or the care team side, we need to learn how to have bedside manner. There's a different way that there is a script even to be able to connect with someone when you meet them for the first time on video. And let's take a pause now that we're out of the surges of the pandemic and solidify that foundation. And then I'll also kind of offer a 30,000-foot perspective, which is that I firmly believe that the telecom industry is poised to jump into the healthcare space in a way that we've never seen before. I think there's some sexy things like hospital at home and the fact that, we have all these cable companies that have divvied up the entire country, and they have both the service people to go to the homes, and we have that end piece, which is the television, right? And so I think we need to be in the game as clinicians and as telemedicine administrators to help guide that. But we need to start partnering now with Cox and Comcast and AT&T. And I think this is going to help us have high tech and high touch in a way that we just can't put our finger on today.
Yeah, and it's interesting you said that, Tina. So one of the discussions I had last year was with the people at the healthcare division of Best Buy. And they have 2 years ago, Best Buy has a chief medical officer, and they are getting more involved in healthcare. And one of the things that they were sharing with me was they have the Geek Squad that goes into all these people's homes to support IT. So they basically had a kind of a pilot program to give TVs away to certain underserved populations, and they used the TV in a vehicle to provide alerts to take their medicine, to call their doctor, or to communicate. And it was just interesting model. It's like, what does Best Buy have to do with healthcare? But to your point, people are starting to see these different tangential areas that are going to be very instrumental in delivering care, and they will be pivotal partners in healthcare, in the future. So it's a great point that you raised. So we are right at 150. Ashley, I don't know if we got any questions from the audience, but I will tee it up back to you to see what question we may have for our panelists. Oh, she just said no questions yet. Okay, fantastic. So one of the things that we didn't talk about, and we can kind of continue our discussion, is maybe and in fact I'll go to Richard on this, is the touch about especially with the care that's delivered to rural, disadvantaged, and underserved populations, and the differences in the disparities and equity around healthcare. So when you are thinking about the inequities in healthcare and disparities, what are some of the the biggest opportunities that can really be addressed given what you've seen in this area of inequities and inequities in healthcare around whether it's racial, whether it's socioeconomic, whatever the case may be? What are a couple opportunities that you see in that space?
Well, the first thing that comes to mind, I also work with students in this space, is in the opportunity for data. So this is an audience of people who've been almost disconnected from a lot of the data that's been created, and a lot of the and some of the benefits associated with it. And I think there's an opportunity to rethink the way we develop apps, the way we develop technology, to truly consider a vulnerable population and our populations who are in need the most, and really look at how do we take the information that they're providing us, not just monetize the data, but really create a cycle where this data is truly helping them, which kind of goes back to what David was saying, really getting them invested, getting people who represent these communities invested in a technology that is there to support them. Their investment will create greater buy-in for them and for others within their community, especially if they feel like they were a part in the development of that technology. So often we come with these ideas that it's supposed to revolutionize and change their lives, and it's just something that we repurpose from something else and just kind of throw at them, and we expect them to just embrace it and say, hey, I'm happy with this, now that I have access to it. But it's not that easy. I mean, we really need to take into considerations the challenges that they face. I'm working with a collection of students now. They'll be presenting apps tomorrow. It's 8 ideas, 8 different apps. And it's very challenging to get them to think outside of their world, sometimes our world of privilege, and think of the world where people are challenged. So they don't have the same access, they don't have the same technology. How do we create solutions that allow them to engage in your technology just as easily as I'm able to engage in it? So that's probably my number one right now, is getting our communities as invested in our technology as the funder is, as the provider is, as the clinical team is, as a policymaker is. We need to get the community that invested.
Yeah, and it's interesting that you bring up high school students. Earlier this year, with the Health IT Day at the Capitol, one of the topics that came out of left field was about the secret weapon of high school students in helping to deliver care to the elderly and also the underserved populations, because they are on TikTok, because they do understand video, they do understand technology. And a lot of them are being raised by grandparents or live in houses with grandparents. And their ability to be kind of adjunct healthcare workers, and even going and looking, volunteering at clinics or whatever the case may be. But it just is interesting you say that, because there's another perspective that this group, this set of people, these students at that age, they can be a valuable asset that a lot of people may not have thought of in the overall community delivery of healthcare, right? So I think it's a great part that you bring up. Tina, I want to bring something up. I know that a while ago we exchanged, I think, a message on something that was posted about the misunderstanding of things like pain levels that are associated with different ethnicities, right? There's some data that was out there about how, and I think the article was 2016, that a class of medical students believed that the pain levels of African Americans, they basically could experience and tolerate more pain or have thicker skin than non-African Americans. But that's 2016. That is like 5 years ago. So even, I'm, didn't go to medical school, and you've gone through medical school. What could be done, or what are your thoughts on helping people that go into medical school to take care of patients have a better understanding of equity treatment of patients, no matter what they look like or even their socioeconomic background?
What a great question. And I think the answer is it has to be multifactorial, because your question is, how do we address systemic racism in medicine? And I mean, we're struggling to do this as a country, and we've just had so many decades, centuries of embedding this in every single facet of life that, we will continue to peel back the onion in medicine, just like in housing and just like in transportation and so forth. And it's going to take some time. But I think, and I'm curious to hear what everyone else thinks too, but one is you have to see the people that are actually training are rising healthcare workers, whether they're rising physicians, nurses, therapists, et cetera. We need to have broad representation. So, while I'm a person of color, most of my teachers were white males. And while you would maybe wager a guess to say, well, you've had a lived experience and you've been in the minority, so that's going to protect you when you become the doctor, it's just not true. When we're surrounded by and taught a certain way, our individual pieces of who we are won't be enough. So I like this idea of diversifying the faculty, the teachers. We may not be able to do that, right? That doesn't happen in 1 year, but guess who we have that is diverse already? Our patients.
Right.
So if we were, I don't know exactly how, I bet you some schools are already doing this, but if we have a way to turn the patient more into the teacher, then I think this might help us. And I think it goes back to, and Richard, I'm curious how you've been doing this, but we have to empower and then teach our students how to actually listen to patients. And I'm going to argue faculty like myself, I also need this training, because I need to undo some of the stuff that I was taught. And I think that would be helpful. And then second, data. We need more and more studies. And while it's going to frustrate some, the growing body of evidence to show the depths to which there's structural racism is the only way. We start out with these large studies, and then we drill down to what we're doing in our practices. And if you have the data, maybe it'll destigmatize and allow us to actually speak about what we need to change.
Yeah, no, that's powerful. That's really powerful. Well, I know I don't want to launch another loaded question with 2 minutes left. So I can't thank you guys enough for your valuable input. I think that the timing is great to kind of reflect, but also look at where we want to go now here in the future. So with each of you guys, and David, I'll start with you. I'd like to, again, just to tell people where they can find you, follow you, et cetera, so they know where to touch base with you. Buy Alio, hire a consultant, Tina, Richard as well. David, where can people find you?
Sure. So Dave at alio.ai. So Dave at alio.ai is the easiest way to get a hold of me. Go to our website. Certainly happy to talk to folks. Excited about where RPM can go, and clinically actual metrics can change patient lives.
Fantastic. Thank you, David. Tina.
Well, I think the best way to reach me is on LinkedIn. And if you actually just search Tina Shah, SHAH, you'll be able to find me. And I'll look forward to connecting with you.
Fantastic. Thank you. And Richard?
Great. For me, it's rgooden at msm.edu. I am old school, so I'm email. You can email me. I'm not heavy on the social media, so email us, and then you can follow us follow our website, or at least go to our website. It's morehousehealthcare.com, and we have a lot of telemedicine related resources and things of that nature there.
Gotcha. Thank you, Richard. And I'm, again, Kirk Barnes. You can find me, best place is probably LinkedIn or also on Instagram at I am Kirk Barnes. And I want to thank everyone that participated as well as attended in this panel. We hope that you have a wonderful and safe Memorial Weekend, and we will close it out from here. So thank you, everyone.
Thank you.
Thank you
Take care.
all.
Thank you.